Thank you so much for joining us this afternoon. We've got a great panel of experts here to walk us through this journey. Before we get to them and introduce them, I want to tell you that at any point during the webinar, if you have a question, feel free to open up that question panel. Drop a question for us. At the very end of our session, we'll pull some of those out and have our experts answer them. Speaking of experts, let's go around the table here. I'll let you guys introduce yourselves and then tell me why disinfection is important.
Thanks, Jamie. My name is Mark Wiencek. I'm a microbiologist with Contec and our technical services group. And disinfection. So disinfection is a process involving killing microbes, and you can't see the microbes and you can't see them dying. So what I want to hope we talk about today is this process that seems somewhat esoteric, that what can we measure? What can we observe that can give us confidence that we are indeed achieving this important task of disinfection? So I'm going to pass it on to Ron, and then I'm going to go get set up over here at the table.
Okay. My name's Ron Sample. I've worked at Contec for a little over 13 years, lucky 13 for me. And prior to that, I did environmental services for a 550-bed hospital and was a building service contractor. So I was operations manager in the acute care field.
Thank you. All right.
Hi, I'm Michelle Knight. I am an infection preventionist. I have been in healthcare for 20 years. I have been an IP since 2019. Disinfection to me means that we're providing infection-free environment for our patients, ensuring that we have eliminated all those microbes that Dr. Mark talked about. And from an infection prevention standpoint, we really want to make sure that all of the areas within the acute care setting are disinfected in our healthcare setting.
Absolutely. We've got a really fantastic webinar for you. We're going to split between going with our panel of experts, asking them key questions on disinfection as well as some demos. But the first part of our webinar here, we're going to talk about disinfectants, how they're made, registered, and delivered. Over to you, Dr. Mark.
Thanks a lot, Jamie. Okay, we're going to get started here with a little kind of simple PowerPoint, kind of taking through. There's some regulatory stuff. It's not the most exciting thing, but it's an important part of understanding how these products are already qualified before you receive them. So, as Jamie mentioned, we're going to talk about what are they as they're sold? What are the different types, the claims? It's getting into about the stability and the shelf life of these products, and what does that mean for you as a user of these products in a hospital. But then we're going to talk about dilution of disinfectant concentrates, because most folks, as we'll talk about, environmental services is going to be using some type of dilution of a concentrated disinfectant. And so during that process, we need to talk about how do we know it's working and what can go wrong, and again, how would you know if it doesn't go right. And then finally, most of these products are applied using some type of cleaning tool, an applicator that starts off dry. So if we're not talking about pre-saturated wipes, and we're really talking about buckets, mop buckets, and other towels that are used with those disinfectants, we've got to think about what that interaction can do to the disinfectant. So let's jump right into part one and say, who actually says this is a disinfectant? Well, a lot of people can say this stuff kills germs, but if you're going to really make that claim legally, it's got to be regulated and approved by the EPA. And so the Environmental Protection Agency regulates disinfectants, and they actually consider them pesticides. I know that's can make people feel uneasy, but understand that this same act that allowed the EPA to regulate disinfectants also regulates all the other kind of chemicals that we use to kill pests. And so in this particular case, the pests are these bacteria, fungi, and viruses that can cause infections in hospitals and other public spaces. And so there's this act, the FIFRA Act, that covers the ability for the EPA to regulate these products. And so what do they really regulate? Well, certainly it's about doing no harm. So we're going to talk about, how does the EPA look at these products to make sure that when used as directed, that they are acceptable for humans to use them. And so really the toxicological profile of these products, as well as the idea that some of them eventually going to get washed down the drain, and we need to understand their environmental fate. What would happen when these chemicals go out into the environment? But when we talk about, well, do they work? That's where the claims of efficacy comes in. So what kind of microbes do they kill? How long does it take to be in presence of that population of microbes before they are disinfected? And then finally, we'll talk more again about the shelf life. How do I know that when I open that bottle and receive that bottle in my facility, that the chemical is still active at the concentration that it was approved? But understand, the EPA doesn't regulate everything. They don't regulate if you've made the correct dilution of that concentrated disinfectant. They do not regulate what might happen if this disinfectant interacts with your wipes and mops and other cleaning tools, and what might happen to that disinfectant at that point. So this is where you as the user within your facility and your team have to kind of think about what can we control versus what we have to rely on the EPA regulating, and that's what we'll get into more today. So disinfectants are formulations of chemicals, but the part of the chemical that kills the microbe is what's called the active ingredient. And so this is what the EPA calls it, it's what we'll call it, and it's the chemical that really does all the work, with all the other stuff that kind of makes it work better, if we can say it that way. And so if we just look at what are these common products that we use in our facilities, quaternary ammonia compounds, long words, so we'll call those quats, hydrogen peroxide, blends of different types of active ingredients that together work better than either one of them alone. And then hypochlorous acid, or things that we would normally use for higher levels of kill, but we can use them at lower concentrations as our daily or low or intermediate level disinfectants. But certainly there are situations where we're trying to kill organisms that those chemicals at those concentrations won't kill. And so here's where we've got to use the heavy duty stuff. And that generally falls to a combination of peracetic acid plus hydrogen peroxide, or basically bleach. And the sodium hypochlorite is that active ingredient in bleach. And so there's many different ways of thinking about what disinfectant should be used against what kind of microbe at what concentration. Earl Spalding came up with the Spalding classification that really looked at this from terms of what type of surface or object am I trying to disinfect, and what is the real risk if there was contamination on that to a patient. So it's really about patient contact and how intimate that contact is. But other folks look at it as just this hierarchy of, if it takes the highest, most powerful chemistry to kill a bacterial spore like C. diff, then that's a chemistry that may stand on its own, that I only really ever use that chemistry for that purpose. But it's a little bit more complicated than that. We think about what does it kill on what kind of surface, but also how quickly. And so in some of the discussion points, we'll talk about why infection prevention might recommend that even if we're not trying to kill C. diff, we're going to use one of these more powerful chemistries. So we talked about, again, concentration of the active ingredients is really a lot of times what drives what you can kill. And so this is an example from a label of a concentrate that actually has 4 different types of quaternary ammonia compounds in there, because again, they have found the combination of these 4 works better than just a lot of one of them singularly. And so if we now look at how these are expressed, again, generally as parts per million or percent. And so without getting into all the math of it, an easy way even for a microbiologist to remember this is 0.1% is equivalent to 1,000 parts per million. And then you can kind of cheat a little bit just to do the math on both sides of that once you just get that stuck in your head. Now again, that's the concentration that the EPA calls nominal. But the EPA allows some variance because they understand there's no way for somebody to manufacture a chemical and it be exactly 0.1000%. We've got some second digits there, but again, they give you some range. And they call this lower range the LCL, the lower certified limit. And you actually have to demonstrate as a manufacturer when you register these products that your disinfectant can kill at that lower level than it's actually lower on the label. This is not meant to cheat and say, well, let me use a lower concentration and save money. It means if something goes wrong, if something's not optimal, can we still be assured that this disinfectant formulation will kill this population of microbes at this concentration? They also look at an upper limit, and they call that the UCL. And this is now to look at what's the highest it might ever be, because we need to think about that in terms of impact on people as toxicology or on the environment. So the concentrates that we'll talk mostly about today will list these actives, but they may also list other concentrations, so your use dilutions, and they may tell you, well, this is the percent that should be. You let it down 1 to 64, 1 to 256, whatever it might be, and they may even indicate the parts per million. So again, this becomes helpful when we start saying, well, how do I know that I've actually achieved that? Is there some type of test? And that's when we'll get into test strips and test kits. But before that, let's finish up with what kind of formats are popular for disinfectants. We just talked a lot about liquid solutions. Ready to use means I don't make any dilution. I use it just like that right out of the container, or I'm making some type of dilution of concentrate. And maybe that concentrate's not a liquid. Maybe it's a tablet. And so I'm adding a certain number of tablets to a certain amount of water to generate a certain amount of active ingredient. During the pandemic, when we couldn't get disinfectants readily, a lot of folks started looking at this chemistry. It's a way to actually make a hypochlorous acid, a form of bleach, if you will, the active form of bleach, from water and salt. Okay, and so that's another mechanism of generating a disinfectant on your own. And then finally, the most convenient, but really reserved, as we'll talk about later, for special situations are these pre-saturated wipes. You've got a ready-to-use chemistry. The manufacturer's already demonstrated it's stable in the presence of the wipe, and now I have that format ability to go ahead and deliver that chemistry to a surface. So once I've delivered it to a surface, here's the other critical issue. How long do I leave it wet to achieve disinfection? So every disinfectant label is going to have this kind of information about how long to leave a surface wet to kill a certain type of microbe. It may say leave it visibly wet for 1 minute to achieve complete disinfection. It's going to be all these kind of ranges of the same type of language. The maximum time the EPA allows is 10 minutes. So this is not like where they will sterilize or process devices in sterile processing like endoscopes, where they may soak them for hours. Surface disinfection's got to happen within 10 minutes. And we know even a 10-minute contact time can be quite a challenge to achieve without reapplication. But another important thing that as a microbiologist, I'd like to point out that I think everybody thinks that it takes 5 minutes or 10 minutes to kill one microbe. That's really not the case. We're not trying to kill just one germ. We're not generally going to run into one germ out in the acute care space outside of a clean room controlled environment. And so we're actually trying to kill millions of germs, because inside the human body, where these germs likely came from, 1 becomes 2, 2 becomes 4, 4 becomes 8, and we're talking about a population of microbes that we need to kill that population within that contact time, not just one single cell. And so a lot of times microbiologists, chemists think about this in terms of percent reduction, because I may be talking about 1 million cells of some type of organism, of a virus or a bacteria or a fungus, and I need to be able to knock down that to a much, much lower level to reduce the risk to the patients. And so we think about things in these nines. You count the nines to get the log reduction, and that's the kind of math that's associated with this process. So to kind of sum this section up, you've got 2 knobs for dialing in disinfection. It's going to be your concentration times your wet contact time. And there's a balance here. So the shorter the contact time, generally the more chemistry or the more powerful chemistry that I'm going to have. There's a trade-off here. And that's what's got to be understood when you're selecting disinfectants or understanding for your team, why do I have to leave this so long? Oh, but it doesn't leave much residue. Well, I'm using this disinfectant, kills very quickly, but now I've got all this residue left behind or a strong odor. So that's the trade-off there. Last slide in this section is really, again, talking about shelf life, because this will become much more important when we talk about what you do after you've received the product. But the EPA does require the manufacturer to prove the shelf life. It's going to be on the label. Could be a date that says EXP, expired on this certain date or month of a year. Is generally, folks try to formulate these products so they at least have 1 year, because they got to make it all the way through the supply chain to your facility and still have some time left to be used, and then maybe even up to 3 years or longer. In some cases, they may even list like what day was it made, or what date it was made, and then when does it expire. But then we've all maybe seen this if we've looked for these expiration dates. They either didn't get printed very well, or they've gotten rubbed off because of the chemistry getting on that surface. Quats are great cleaners, and they can remove this ink if it wasn't printed properly in the right place. So that can be a challenge, but that's where you again got to work with your vendors to say, I need to know that I'm getting product that's not already expired by the time we're trying to use it. And then understand that this is only as the product is sold. Once I get to this idea of putting it into making a use dilution or mixing it with other things, that doesn't apply. Now, oftentimes manufacturers will include some information on the label or other language, other bulletins that says, after you make your dilution, you can use this product for, say, 1 day or 1 shift. But understand, that's a new clock. That chemistry has now become unstable because you've made a dilution of a concentrate. And it's a new clock that's much shorter than the original clock. So just keep that in mind when you talk about how long am I going to use a product after I have made that dilution. And then again, as we'll talk about later, once I start soaking or wetting an applicator and letting it sit throughout a shift, that also is going to change the time frame of how long that product is stable. So before we get into part 2, I really want to take this back to our committee over here, our group, to talk a little bit about, particularly about how disinfectants are used in healthcare facilities by different team members.
Absolutely. Thank you so much, Dr. Mark. We are with a former EVS operations manager as well as our infection preventionist here. Thought we'd be a good time to ask how these different departments interact with disinfectants. So Ron, I'll let you take it first.
Okay. In EVS, we tend to operate through dispensing systems out of closets, either laundered microfiber or towels and mops or single use, depends. But the main thing are disinfectants. For a large portion, most EVS operations are coming out of a dispensing unit out of a closet. In some cases, you'll see some pre-saturated wipes. Mainly, in my experience, clinical tends to use these more, and I'll let Michelle kind of expand on that. In the EVS market, based on my prior experience, I'm a big fan of using charging buckets and wipers inside of those, because when EVS uses these tubs right here, they tend not to use them as well. Michelle, when we take a look at these wipes from an IP standpoint, and some of them come larger than that, some don't, but this is a standard wipe, and if you want me to clean a toilet, a bed, some of these bigger areas, most of the time EVS will gang pull these and they'll wad them up and they'll go forth and clean. You get trailing, you get a lot of issues with them. And again, if I was going to clean something smaller, this is fine, but the larger surface areas, they tend to misuse them. And Michelle, I'll let you kind of touch on that. What's your thoughts on this?
Yeah, so speaking about the wipes, specifically you want to use wipes in the clinical area, these are for your clinical staff who are doing those point of use items, you know, where you want to focus on like glucometers or iStats or blood pressure machines or those high touch surface areas like a doorknob as the nurse is going out of the room. These are meant to be quick acting, small things that the clinical staff can do and move on from one task to another task to another task. Using big ganging up of those is not ideal for our EVS staff. Right. We want to stick to using these that are intended and have manufacturer's instructions for use with equipment that is designed for these type of wipes. Okay.
And then as I know, working in the field with infection preventionists across the country, this always comes up, that lid open.
Yeah. And one thing that is really interesting about the lid, CMS requires for you to have that lid shut at all times. So that could lead to a citation within your hospital system if you do not have the lid closed. And the reason behind that is if you leave that lid open and that wipe exposed, you now have a dry section on that wipe that does not have any disinfectant on it. And therefore, you're not properly disinfecting to what the EPA has said that this wipe will do.
Could be uniform with distributing pathogens, couldn't you?
Yes, you could. Yeah. Absolutely.
So, and just for that purpose alone, from an environmental services standpoint, they tend to operate from charging buckets, which takes us back to that discussion of, do you have good chemistry coming out of your dispensers? And so, Jamie, I'll pass it back to you.
Yeah, so we've heard a little bit about kind of the process. How can infection prevention and the EVS team partner together for a better disinfection process?
I think that's a great question, Jamie. Really, EVS really needs to partner with IP on every level in choosing every type of anything that you're going to use in the hospital system, because IP and EVS are the front lines for making sure our hospitals are safe and clean for our patients, making sure that we have the right disinfectant paired with the right tool, because we could put as many as disinfectants we want to on a surface, but if we don't wipe it off or use it properly, then we've just created biofilm, which creates a whole nother problem. So just ensuring that we're working together, and EVS and IP have that relationship together to ensure that we're meeting the goals of an organization in healthcare, I think we can really increase patient safety and our staff's safety.
Now, I've seen out in the field a lot getting infection prevention involved with your unit managers, because in some cases, Dr. Mark had mentioned, you got a 10-minute dwell time on a chemistry. Well, if the expectation in the labor and delivery section or in the operating room is a quicker turn time than that, I've got to take a look at my infection control bundle. We've got to go to something that has a shorter kill time. That could involve changing chemistry, active ingredients, and what you pair that up and apply it with, the mop or the wipe, is even more important in that case, because you do not want to interfere with the efficacy of that chemistry. And just working together as a multidisciplinary team between unit managers and infection preventionists and then the EVS, but even in long-term care, you've got people that are following those same sets of criteria. It's all about resetting that infection prevention clock, if you will. And thanks for that interchange.
Absolutely. So we're going to go back over to Dr. Mark now, who's going to talk to us about the proper dilution of disinfection.
Thanks a lot, Jamie. Again, this is what we really enjoy, is having this diverse opinions from different folks, different stakeholders within healthcare facilities. They all got to work together, but they do have legitimate differences in what they're trying to achieve on a daily basis, and that requires a lot of times different tools and different processes. So one thing, again, getting back to what an EVS typically is going to do, and not just EVS, this again goes to any kind of janitorial services, frankly, likely are going to be relying on concentrates. Concentrates require less effort to get them into your facility. You're not shipping water. Generally, because you're not paying for the water, you're supplying that yourself. They're less expensive on a per volume basis or per weight basis. But there's, again, responsibility that comes when I am starting with a concentrate. And so that comes with what dilution do I need to make to actually perform. And so there are different dilutions oftentimes for different concentrations depending on the disinfectant. And so higher concentrations or less dilution might be needed to harder to kill germs. So here's an example where there's a dilution series of 1 to 16 or 8 ounces per gallon. If I really want to have a broad spectrum bactericide, kill the fungi, kill the viruses. But let's just say maybe I'm using this on a cruise ship to kill norovirus, and that's really the only focus of what I'm trying to do. Well, maybe I can go with a more dilute series of this, more dilute formulation, and still be able to achieve that disinfection. And then this label even says if I use this in extremely dilute form, I'm not expecting it's not approved to kill any microbes, but I could still use it to clean. So again, you'll find this series of different dilutions that may help you use one product for several different purposes, but you also got to manage that and keep track of it. The other thing we talked about again, more concentration. Higher concentration generally means a shorter wet contact time with all other things being equal. But let's get into the real mechanisms of how we dilute. I guess in some situations, if you're really in a pinch, you're going to be doing some kind of glug-glug out of the jug, but that's not really the kind of consistent process that we would ever want to see in healthcare, and certainly would not be what's going to get you the best responses consistently over time. You got to at least be doing something to measure how much concentrate am I using versus how much water am I diluting it with. And then it gets into all about the quality of the water we're using. We're not even going to be able to get in that today. There are other ways of metering that dose, if you will, to somehow mix that concentrate with water. But again, probably not the most precise type mechanism. And so folks have these stations, these dispensing stations for mixing the concentrate with the water. And because these are so popular, they oftentimes are used to dilute several different products. So you put your different concentrates in the right slot, hopefully, and you're selecting the right button that's giving you the right dilution of that product, be it a hard surface disinfectant or perhaps a neutral floor cleaner as 2 examples, and maybe a glass cleaner being another. Very different purposes. Do not want to be getting those mixed up with one or the other. Again, so good that I'm going to show that slide again and then switch to this one. Okay, so how do I maintain these automated dispensers? Well, a great article came out last year. It was somewhat even the genesis of how we started going through this process for this talk. And this is from Dr. Donsky's group, led by Jennifer Cadnam. And they went and looked at a lot of different facilities to understand 10 different hospitals. Let's look at all these episodes of dispensing and diluting a disinfectant and what's really going on there. And so if they went through testing 107 different dispensing, at least maybe not 107 devices, but 107 events of dispensing, they found a lot of discrepancies, a lot of variability. There were, maybe 50% that were in the range that were supposed to be, but there was a considerable amount that was too high, so not diluted enough. So I've got too much active ingredient. We talked about the bad things that can be associated with that, or too low, or maybe not even any disinfectant at all. So when we talk about how these kind of things can happen, again, this is a device, but it also requires some manual intervention. There are parts of the bottle and tips and devices associated with the bottles themselves that have to be hooked up appropriately for that kind of dispensing machine. Or if the bottles are put in the wrong place, just all kinds of bad things can happen here. And so whether they were not set up properly, or whether some of the tips that are associated with either the device, the dispensing device, or the bottles got clogged, maybe not flushing appropriately in between one chemical and another. This is how we end up with disinfectants that are too low. In some cases, again, too high. Was this because they weren't set up properly? Was somebody thinking, oh, more disinfectant is better? We're doing a better thing for our patients. Well, as Michelle said, we also got to take care of each other. And we don't want to be using disinfectants at a higher concentration of what they're approved. That's not going to get us any better effect for our patients, and it's potentially putting people at risk. Is there equipment malfunction? Again, some of these devices fairly simple, some of them a little bit more sophisticated. And again, there are opportunities. They just require maintenance. Let's just put it that way. And that's something that you should be working with your vendor to make sure that happens. And then understand, we talk a lot about disinfectants because they have contact times, and we just talked about how the concentrations match to the contact time. But think about your cleaners too. Cleaners were designed, hopefully if they're good cleaners, by nerdy scientists that said, this is the amount of cleaner that gives the best outcome. And if I have too little, I'm not going to have that positive outcome. But guess what? If I've got too much cleaner or too much disinfectant, I can have all these residues leading to biofilm that Michelle talked about, exposure to workers, damage to materials like corrosion. And then actually, guess what? Some cleaners don't actually clean as well if they're too concentrated. And then finally, again, we're just wasting money at this point. We're not using products as directed. So again, that is kind of talking about the potential for problems. But then you just say, well, how can I know whether I have a problem or not? Well, again, your vendors that's selling you your machine and your products should also be a partner with you about helping you understand whether the product's working correctly and helping this education. But there are some things. There are some products that have characteristics, odors and colors and suds that when you know it's working day after day, this is what it's supposed to look like. And if something like that's not right, as Ron will say several times today, something's not right, tell somebody about it. But we've also got some relatively inexpensive ways to measure for active ingredients or through a characteristic, a property of the product like pH. Guess what? This also requires a little bit of work. There are a lot of different test strips that are used for different types of products. You've got to match the ingredient and the range and see whether the range of strip I have even goes within the range of what I'm trying to target on my disinfectant. They also have different instructions for use. Some of them say read it right after you dip it into the disinfectant. Other ones say wait 5 to 15 seconds. Some shake it off, some not. You got to read all the details on this because they're not all the same. Again, they're going to be revealing the results in a parts per million. So again, you can go back to your label, use that 0.1%, 1,000 ppm reference that I mentioned, and figure out, am I in the range that I'm supposed to be? You don't have to do this every day, every time. I don't think that's warranted, but there needs to be some spot checking that goes on, particularly if somebody observes something's not right. Now, guess what? Test strips expire too. There's chemistry on these strips, and that chemistry can expire. Those chemicals can go bad. So you got to check the date on that as well. But what we want to talk about next is a little bit of a demo that says, what's this idea that my wipers, how my chemistry reacts with my wipes might actually signal that something's not right. And so Ron's going to come over here and show us on camera what's going on with that. Welcome, Ron.
Hey, Doc. How you doing?
Good.
So what we have here is a series of wipes up here on the table. Sorry about that. I had to bend down and grab that. Probably not real good for the video. But what we've got is Contec Clean Cloth. It's a single-use microfiber with wipe with the microfiber technology in it. Comes in rolls. Comes in quarter folds. It's the same fabric, doesn't matter which format you have it in. But we've got a wipe right here sitting on the table, and we've got our quat test strips. But right here, as you can see, we've got some bottles right here, little beakers, and one of them is labeled quat, one is water, and one is a quaternary ammonia, but it's mixed a little light. It's not quite right, as Doc had said. So what we're going to do is go ahead and take the water and put it on the Contec clean cloth. Now what you'll notice here is this fabric is hydrophobic, meaning it does not like water. So what happens if your dispensing system is not working is, plain for everyone to see right there, that towel is not absorbing that water. And it's not going to. Now, if I've got good disinfectant, this is our quat right here, and I'm going to go ahead and pour it on here. This is the quat. We're going to go ahead and pour it on. And the section of towel that I poured on, you'll notice it immediately absorbs and activates. And so I've got good disinfectant in this beaker. The first one I had water. But what happens if you get something like Doc had talked about that's weak? Well, if you'll notice, we've got good, we've got water. Here's something in between. It's not quite right. It's taken longer to soak in. The video here doesn't quite show it as good, but this is not as saturated as this other portion of it. Now, this fabric is nothing more than a visual assessment that you've got something afoul with your system. It does not in any way, shape, or form take the place of test strips. These test strips are needed, but you need to have some sort of indicator at point of use that when you're out here using these wipes on a daily basis, do I have good disinfectant or do I have water? And if I've got something in between, I've got something that tells me that. Now, one of the things, Doc, I don't know if you want to step over here and kind of talk about this. You can see where the water is on the towel from the overhead. And when you go to the overhead, you can see the water's right here puddled up on it. We've got disinfectant here, but watch what happens when I add this is good quat. Mm-hmm. When I add it right here, kind of breaks the surface tension of that water. And you can see where the water was. It's still not quite wet out. You can also see where the disinfectant was too weak. Mm-hmm. It's not as wet as the quaternary ammonia. Now, when I pour this, even where the water was, and I get enough active ingredients to overcome that water level, this fabric wets out. But I have to have enough active ingredients. I've got enough active ingredients here, but I'm lacking here. It's not perfect. It does not take the place of a test strip, but it is an indicator. If you've got 75 dispensers in your 550-bed hospital, you've got a tool here that helps ensure your infection prevention bundle is at least effective and efficient up on the road.
Now, that's pretty cool. We've seen this before, and again, it does show the hydrophobic nature and how the surfactant, quats have surfactant in it, other disinfectants, several of them have enough surfactant to break the surface tension on this white, and how that diffusion kind of occurs there. But generally, folks are not going to be just doing something on a single white, right?
That's correct.
Generally not. They're not. This is not a pre-sat, or they're going to be doing. So take us through what the experience would be if somebody's actually filling at a station. They're going to put their. I think y'all we recommend 1 quart for these and these.
1 quart.
So
These come in a bundle.
This could be interesting here.
They come in a bundle, and what we're going to do here, we've got water for one.
Let's scoot these things over here so we can
all right,
put them in there and don't make a mess.
Right. We got water for one. We got quat for another, and we've got our weak mixture right here. Now I'm going to go ahead and start with the water. Now these are charging buckets. You're going to put them in here. Now, I'm going to pull this top back. I'm going to set this where we can see this over the camera. If I've got just water, my dispensing system is not working correctly, these wipes will reject it. And I don't know if you can see, these things are actually
come out of the bucket.
They're floating.
Yeah.
And that's a problem. these towels literally are having like a bobber effect. They're not working. My dispenser has got issues. I think on that chart that the team, Dr. Donsky's team was looking at, that accounted for
14%. 14% they found had no disinfectant measurable at all. And so it's not like it's that rare. I mean, I think that was the big wake-up call, is that...
If you've got 50 dispensers every day and 14% of them aren't working,
yeah,
you've got a unit that's not being disinfected.
That's right. Yep.
So that's the water. Let's go ahead and rotate these out. Now here's the quat. Put the water over there, Doc.
Yep.
Now the quat, save that bucket up top side here for me for a minute though. We'll go ahead and pour the quat on here, and you'll notice something. The minute I start pouring this in, these towels are not floating, they're absorbing. And when these things charge, they literally charge. They soak in the disinfectant, and they start absorbing that liquid almost immediately. They're not floating around in this bucket. I don't know if you can tell or not in the camera angle, there's hardly any liquid left over. These are good wipers. Mm-hmm. I now know I can go clean and disinfect with confidence coming out of this charging bucket. Now, that was our quat. Now, what if our dispenser's acting a little funny? There are several different dispensers out on the market. Find out what you've got, because some dispensers actually have the portioning tips that's inside the individual bottles, and when you plug it into your dispensing unit, you change a fresh tip every day.
Oh, okay.
Okay, and that's a pretty secure method right there. They still have a few little quirks in them, but all in all, that's a great process. You've got other dispensing systems that you have to actually put the tip inside the dispensing unit. It can get clogged. It can get gummed up with hard water stains, with hard water and different things in it. Team members can get in there and start trying to play chemist and mess them up. So you've got that. Now, what happens in a situation where you've got towels and you've got kind of sort of disinfectant? Is that a thing?
I see some suds. I mean, I would have thought maybe I had something in there. Yeah.
If you'll notice, the towels are kind of taking them in, kind of not. If you'll notice inside my bucket, you see that water pooling up? These towels are still kind of floating, and we're kind of not disinfecting. We'd better, something is wrong. At that point, go back. This is nothing more than a visual assessment. Mm-hmm. This is the indicator. Well, something's not right. Go get the test strips and validate your process. When you've got a 550-bed hospital, you may have 100 staff members cleaning between your 3 shifts, and they're changing charging buckets in between each shift. Hope is not a plan.
Yeah, that's a lot of different opportunities. That just if somebody can notice that, we can get the supervisor in there before everything is now spread out on the whole floor, and it could something right when they're filling their buckets that they can notice that.
Yeah.
Yep. Mm-hmm. All right.
Now you want to do
We've
some
done
rolls.
this before. I want to see the rolls.
Doc likes the bobber test, as he calls it.
Yeah.
So we'll go ahead and do put the quats here. Here's a 25% quat, and for the camera angle coming straight ahead here, this is pretty, we need two bottles each.
Oh yeah.
The rolls are a little bigger, so you've got to, each roll has to have 2 quarts. So let's go ahead and start with our quat. We've got a roll right here. We're going to pour a quat on top of this. You'll notice it's absorbing into the wipe like it's supposed to. One bottle down.
I mean, how many things can they wipe? I mean, that's a massive
75
roll.
wipes in here.
Okay.
And they're a bigger size wipe. Again, these are primarily intended for EVS or probably clinical techs.
Yeah, but they got to cover a lot of space in a
That
short
are
period of
doing
time.
beds.
Yep.
Larger equipment pieces like Michelle talked about. These are not just medical devices or small areas. This is a wipe that is actually this big. And so this is not a 6x9. It's like close to being a 10x12. But you'll notice this roll is sitting down in that bucket. I don't have a lot of liquid left over. Now, let's go to the water one. I'm going to go ahead and jump right here to the water. I got to be careful when I do the water because these towels are not going to like the water. You'll see it's acting a little funny, Doc.
Oh yeah, just here it goes.
Yeah, we were in a food processing plant in obviously not a hospital, but a non-English speaker was called a whole stop to the sanitization and disinfection process because the towels weren't working. It wasn't the towels.
I don't think you're going to get that other quart in there myself.
It was the disinfectants. Actually, the sanitizer in this case was not wetting out. And so this is, you got to be careful. You will get, somebody will call you from the unit and tell you something's not right with the wipes.
All right. I hope we don't short out their equipment. Wow.
So
look at that. It ain't going in either.
It won't.
It's not going in. I'm not supposed to say ain't.
Now here is our weak dilution, the 25%er. So this has got some quaternary ammonias in it. It's going to saturate somewhat.
Yeah.
But
I see it moving.
It's going to kind of float too.
Yeah.
And you get the same effect with the square towels. But if you'll notice, let's take this wipe and get it out of the way. When I put this second,
it's creeping. Here it comes. Yep.
And I've got
roly-poly.
And this is what I mean by, these towels are not test strips. They're visual assessment. But I know this wipe is charged and saturated.
And it's what it's supposed to be, and it's what it was yesterday.
This one,
something's not right today.
It's kind of sloshing around in the bucket. Something's not right.
Yep.
This one,
look out,
definitely ain't working. And again, there are a lot of different wipers out on the market. This is something that Contec is the industry leader in manufacturing wipes for critical environment. This fabric went became very active during COVID for us because of these same features right here. Again, a quarter fold for your EVS. If you do want rolled wipes, you got it here. But what are you doing? Are you disinfecting, or are you uniformly spreading pathogens, or are you just kind of cleaning? If you're in a healthcare, long-term care, or in a critical environment, you're supposed to be disinfecting. And to do that, you've got to have active ingredients.
Thanks a lot, Ron. We've never actually done some of these before, and so when you're doing them live like this, so we kind of knew what to expect because we know what hydrophobicity does. So to set us up for the last section here, we're going to talk about the interaction of disinfectants with wipes.
Okay.
And that's going to get us into some things that we want to take a look at, not just the Contec Clean Cloth, but a couple of other products, typical type towels and wipes, some that else that are offered in the marketplace. So if we've got some quat left, I think we left some in here.
Yep.
At the good stuff. Let's take some of these other towels and soak them up, because when we come through this final section here, we're going to come back here and we're going to use these test strips, and we're going to understand what happens when the disinfectant meets the wiper before you're using that wiper to put the disinfectant on a surface.
Okay. So we've got a laundered microfiber. We've got a single use applicator, and then we've got the Contec clean cloth. So we're going to take one of each, set them here on the table. I'm going to go ahead and get these out of the way. We've got test strips right here. And we've got one for this one. We've got one for this one. We got one for this one. And we've got one for our control. Now, just to show everybody, we're going to come back to this, and there's a little bit of trust here involved. But this disinfectant, I'm going to go ahead and pour it on the Contec wipe. Is good disinfectant.
Again, these test strips are not like a HP, they're not high performance chromatography. They are actually called paper chromatography. But they are telling you a little bit about the color, that's telling you a little bit about what that dose is of that disinfectant. It's a range. So again, you're not looking for absolutely matching what's on the label. What you're looking for is, do I have a big problem? Has something gone awry? And so you're generally not adding your disinfectant right to your wipes and then using the wipe right away. The wipe's sitting in the disinfectant for some period of time. Well, if the wipe's not compatible with the disinfectant, you're going to start to see disappearing of your disinfectant, and that's what's going to happen when we finish up this last bit here.
I'll set this back here.
So while we're waiting for that to happen, I'd love to go back to Michelle and Jamie and talk a little bit about some other areas of the hospital and other things that we run into where disinfectants become really important.
All right.
And they get to do another acronym, so that's good.
It's great. You love them things.
Yeah. Go ahead, Jamie.
Thank you so much. You guys are having entirely too much fun over there. Michelle, let's talk about MDROs and the importance of combating them with disinfection. So let's talk a little bit about this. Tell us a little bit what that is, some of those concerns we have in the healthcare sector.
Yes, MDROs is multi-drug resistant organisms, for those that don't know what that means, and they are a nuisance to infection prevention. We do not want those in our environment. We want to make sure our surfaces are disinfected to kill those MDROs. And what you often have to do is use either a longer wet time or a higher concentration, depending upon what is the best for your facility. But you have to eliminate those MDROs on the surfaces, because you want to ensure that in the acute care setting, you don't have a cross-contamination from the patient that was there before to the patient that's coming into that area. So you want to make sure that you do a thorough clean with disinfectant to that, and making sure that you keep the right wet time at the right concentration of the disinfectant. So that is really where the two really meet when you're disinfecting a surface.
It sounds like to me that both process and product are crucial in combating MDROs. Is that true? Do you find that to be true?
I do find that to be very, very true. You could pour something over an MDRO, but if you don't make sure that you've wiped it and kept the right wet time and all of that, you haven't removed that from the surface. So you got to make sure you have a good process along with a good product, and that both are together and married, and that you are removing that and breaking that chain of infection that Dr. Mark and Ron talked about earlier. Breaking the chain of infection is what really stops MDROs from spreading throughout healthcare facilities and long-term healthcare facilities.
Absolutely. All right, I think our guys on the other side are ready for our final part. I'm going to throw it back over to them.
Okay, thanks a lot, Jamie. Coming down the home stretch here, appreciate everybody's patience, but again, trying to give you some real-world examples and some expertise from folks on the front lines. So let's again go into these applicators, these wipers and mops, and what can happen here. Again, most processes involve applying a disinfectant with some type of tool. As I said, some wipers and tools can actually interfere with the disinfectant. This is the most common thing as happens with quaternary ammonia compounds. Again, the most popular disinfectant class in the marketplace today. And so that's why we focus on it, because that's what most folks are using for their daily, their low and intermediate disinfection. But there are some other chemistries out there, I mentioned hypochlorous acid, that also can degrade or react with different textiles. And so we'll talk a little bit about that as well. The effect increases with time. So that's kind of why we started this just a couple of minutes ago, so that we give the chance for the chemistry to happen. But it does happen, and for some textiles can be almost instantaneous. Again, Dr. Donsky and his team with Jennifer Cadman and this other great team from the VA went and looked at not only the disinfectant coming out of the dispensers, but what happens to that disinfectant if I go start pulling it from the EVS's mop buckets and wipe buckets. And so again, found out, okay, 61% just about right, but that leaves me 39%, a good amount, that's not right. It's either too low, there's no disinfectant at all being measured, 18% in this case, or I've actually got the wrong product in there. Somebody's supposed to be using a disinfectant, they're using a floor cleaner or a glass polisher. Holy cow. So again, there's opportunity here for improvement, and that's where we love where these scientists go and do this actual research to be able to figure this out. Now, folks go, I hear a lot about quat binding, we've heard about it from years, we've even heard it from Contec. What is quat binding? Well, it gets a little nerdy here. The disinfectants are actually positively charged. It's a part of the molecule that actually allows them to react with germs. Turns out germs tend to carry a negative charge. Bacteria, fungi, viruses tend to have a negative charge. The positive charge on the chemical reacts with a negative charge and actually busts holes in the cell membrane or cell wall of the germ. That's how it kills them. That's great. Guess what? Detergents, like we use to clean our microfiber, towels and mops, also are negatively charged. So are some of the very substrates and materials we're using to make these mops and wipes. Cotton, cellulose, rayon, even polyamide or nylon carries a negative charge that can interact with these disinfectants. And sure enough, dirt, if left over from reusing products that haven't been cleaned properly, be it the software, the textiles, or the hardware like our buckets, that dirt can interact with quats. The quat's great, but it's not smart. It doesn't know the difference between a negative charge on a microbe and a negative charge on a piece of dirt. And so that's why we've got to minimize that amount of competition for this product when we're using it. So Ron, before we actually show some data where we've done this in the lab, take us back here. Let's show everybody what the demo shows in terms of these different products and this quaternary ammonia compound.
All right. So again, we used our quat. We had active ingredients. We tested it with our test strips. We've got the 3 players right here on the table. This is a laundered microfiber towel. I'm expressing, because we're not testing a charging bucket, we're not testing the towel. We're supposed to be testing the disinfectant as applied to the patient's surface.
Uh-oh.
And as you can see right here, where am I at?
See where you had quat on your finger, and that's about the only green I see.
Yeah.
Mm-hmm. No, not
So,
much there. Wow.
Nothing. This right here is a single-use wiper, competitive wiper.
Yeah. So no dirt on that. It's made from the wrong stuff.
But if it's got
Oh boy.
again, I'm nowhere near 600.
No, I think you're at the other end of the scale. Yeah. Mm-hmm.
So, no good there. Let's go ahead and go here. This is the Contec clean cloth. Doesn't have any of those bad fibers in them. Never went through a laundry. And it's green.
Yep. We're up there about close to what we're supposed to be for that quat.
Good to go.
Yep.
And so, how your wipe interacts. Now, we're using quaternary ammonia here on the table, but as Doc had mentioned, there are other active ingredients, celery hydroperoxides. There's alcohol blends. Some folks are still using phenolics out there. Find out what your active ingredient is, get a test strip, and make sure whatever wiper you're you're applying efficacious disinfection, because your infection control bundle, as you package it together, is about delivering disinfectants or sanitizers to a surface to reset that infection prevention clock. And the marriage between your fabrics, whether it be a wiper or a mop, is everything. If you're using mops to terminally clean an OR, the whole process of washing those ceilings and walls is to disinfect and reset that infection prevention clock.
Yep.
There you go.
All right, Ron, thank you so much. I want to take folks to this last bit. We're getting short on time. We want to have time for a little bit of questions here. People can hang on. We've done some studies. Others have done this as well. Dr. Boyce has done this, others, but you can measure these quats with test strips. You can also use other little bit more sophisticated equipment. We essentially call that titrations. And we can measure how much quat's remaining after soaking like 10 or an hour, 10 minutes or 60 minutes. And again, we see big differences between a compatible textile and a laundered microfiber mop pad that just has not been properly taken care of. And it's really hard for microfiber to get laundered because it wants to grab hold of dirt and things and not let it go. And then if I go too harsh with that, then I may actually damage the microfiber. And then how many cycles? I don't know. When we grab this stuff, it doesn't say how many times I've been laundered. And then if we look at just that same wipe that you talked about again, okay, if I just go single use, does that solve my issues? No, that could mean that you're using a product again that's not compatible. And so here again, even after 5 minutes, have lost almost 50% of that quat from biting into that towel. And then I mentioned again about hypochlorous acid. Again, that's what it kind of looks like. It's again a simple molecule. It's a way of delivering chlorine. It's very effective, but it's also very reactive and has a relatively short shelf life, even in the bucket. But now you added some kind of wrong cloth in there. I mean, we're seeing some loss even after 1 and 2 hours with Contec clean cloth. It's very reactive chemistry. Yeah. Okay, that's where you may have to change a process from a soak and go to a dip and go. Okay, that's where we get into a different kind of discussion about how to minimize the loss of disinfectant over time with the tools that I have. But when you take that microfiber towel, 1 2 hours, it's gone. That chemistry's gone. You're not doing anything to that surface except spreading salt water. And bacteria like salt water. All right, that's the whole thing about the software, the cleaning tools, but don't forget about these other cleaning tools, the buckets, the mop frames, the things that touch your wipes and mops, and things that can bind up your disinfectant. We did a nice webinar about this called Bugs in the Bucket. Please check that out. You can scan that QR code. Again, these slides will be available, and you can check out that link. A lot of good content on Contec's website related to how you can protect your investments within your facility and protect your patients. Wrapping this up, again, know your disinfectants. Concentration times wet time, the two things you could control. Try to get a handle on controlling those. Understand your products by looking at the label. What is the target microbes? Why am I using this product to kill what microbe? And then find that expiration date. Ask your vendor, where can I find this? Why is it not legible? And then make sure you're using your products as safe as possible as directed using the SDS and the product label. If we're now having to dilute these disinfectants like most of us are, communicate those expectations with your vendor. Ask for posters with visuals, not long, complicated technical bulletins that people are not going to be able to read or take the time. Make it visual and make it easy about how they can know that the product's working, the device is working correctly, and get you some test strips. And then have that communication where it's not just complaining about, I don't think I want to do this today. It's about, do I have the right tools to do the job? Something's not right. Please come take a look at this, because something doesn't smell right, look right, or feel right when I'm dealing with this disinfectant. And then keeping your cleaning tools clean. Disinfectants, we got to have them, but they're very dumb. They don't know the difference between dirt and germs. You need to know that difference and keep your cleaning tools clean. And then finally, as we talked about before, I like saying it because it's rhymey, if the wipes are dry, the germs don't die. But if we've got to keep these products wet if we're going to get the investment that we're putting into these pre-saturated wipes. You got to close the lid. I know it's a pain because you got to close and open it every time. That's what you got to do. And as Michelle said, you can get written up for it if you don't. And then, yeah, no gang pulling. Again, there's plenty of other wipes out there. You don't need to do that and run through a whole canister of pre-saturated wipes. So again, a lot of information in a short period of time. I think we still may have a couple of minutes for questions. If not, if we can't get those today, then we will certainly get back to you if you can leave your information and give us a chance to help you out in the field. In the meantime, Ron, let's go on back there and see if we can at least get a couple questions done here before people say, I've had enough.
Hey, ladies.
Hello, welcome back. Fantastic job.
Thank you. I had fun.
Like Dr. Mark said, we are running a little bit long, so we understand that if you need to leave, feel free to check your inbox. We'll be sending out this information and a link to the webinar, on-demand webinar through your email. But we do have a couple of questions. I'll get started with one that was sent in when people registered, and they wanted to know more about long-term care facilities and disinfection. And then I know, Michelle, you and I were talking about that. Why don't you start us?
Yeah, disinfection in long-term care facilities is crucial. We send those patients from the acute care setting to the long-term care facility. And that's where you'll find a lot of your MDROs. Those are the patients that are on your long-term antibiotics. Those are the patients that have long-term indwelling devices. They bring in stuff from home. They have more visitors. So keeping that space clean and disinfectant is really, really important so that those folks don't end up back in the acute care setting. They're sent to long-term care so that they can get the care that they need, and it needs to be as clean as it was in the acute care setting. So making sure that we carry that over from the acute care setting over into the long-term care setting is crucial, especially when you add all the family members and the personal supplies and all of that stuff in, making sure we're cleaning those high-touch surface areas. That's very, very important.
Absolutely. Dr. Mark, have you had a chance to look over some of those questions that have poured in since the webinar?
I know. I wish we had more time or I talk less so we could get to some more of these. So I apologize. Again, we had a lot of different pieces going on here, but I really appreciate, again, not just me standing in front of PowerPoint. It's so boring. So, yeah, there's a lot in here. Ron, there was one talking about, I don't know if that was in the demo that was filmed or what you were doing here, about not closing the top of the pre-moisten. They may have said that before I said my jazzy thing about you better close that lid because if the wipes are dry, they don't die, the bugs don't die.
Yes.
So again, I think that was just part of the demo. That would be something, again, it's a challenge. Even if you have a self-closing lid, people get their finger trapped in there. But you got to have the right amount of disinfectant on there. And some of these disinfectants, like even the ones we're using, have alcohol as one of their components. That flashes off very quickly. And so you got to just follow what you got to do there. And I know it takes more time, but that's what you got to do.
Absolutely.
To touch on that, if you're in a charging bucket situation, you may not have lids inside your EVS carts, but normally they affectionately call it the barbecue grill. Where they've got a lid that closes over to keep contaminants out of it and also to keep it safe from other patients and stuff. And then there's other different housekeeping or environmental services carts where they actually portion liquid right straight on the mop or the pad as you use it, kind of like a dip and go system. But keeping the lid closed or keeping the chemistry out of reach of others is everything. If you're on a pre-saturated wipe, close the daggum lid.
Yeah, I mean, you do have some excess liquid in your bucket. You do have the opportunity to add some more. It's a lot of different situation than a pre-sat. You're not going to be using generally a product that has alcohol as one of the ingredients when you're doing this kind of EVS wide spread disinfection. So that's not as critical. But again, most of the buckets do have lids, even if it's not a self-closing lid. Yeah. I think you mentioned somebody asked about water quality as well. Again, the labels are specific. The EPA does require certain types of hardness of water, and you have to be within that range. I'm not telling people to go test the hardness of their water, but this is not something that should be changing a lot. So if you know you're in a place with hard water and scale that builds up, then there is that you do have to look at the labels and make sure that you don't have to adjust your concentration or that particular disinfectant's even suitable for that type of water. But yeah, the quality of the water definitely can impact. If the water's dirty, you're already now doing something to your disinfectant to degrade it. Yeah.
Absolutely. Microorganisms build resistant to disinfectants like antibiotics. This was a question that came in. Can they build resistance? I think, Michelle, we talked about this with MDROs. Dr. Mark, tell me a little bit before we go to Michelle about some of the things we can do to prevent some of that in terms of process.
Well, again, we could have a longer discussion on it. So let me just say, again, antibiotic resistance, real, a big problem. The mechanisms of how antibiotics kill or inhibit the growth of microbes is fundamentally different than disinfectants. So disinfectant resistance, the point where my quaternary ammonia compound is no longer going to be able to kill, I'm going to have a failure because the microbes now become resistant to it. The evidence is not there in the marketplace. There's a very few cases where we've been able to demonstrate that if I have a little bit less ppm or more ppm of, it takes a little bit more ppm of a chlorine to be able to kill a microbe. There is some adaptation that goes on. Bacteria do interact and respond to environmental conditions. But this is just not like the form of antibiotics. Antibiotics, once it becomes resistant, it doesn't really matter how much more antibiotic I add. It's not based on concentration. And then there's a point I can't add anymore because it's above the therapeutic safe dose. So again, antibiotic resistance, disinfectant resistance, totally different mechanisms. Neither one should be ignored and should be discussed, but that becomes a greater discussion of there's nothing really you can do to say, well, I'm going to do this to avoid disinfectant resistance, because it's not been proven to actually be worth something to change your behavior.
Did you have one? We've got our list of questions here that came in. I think, was it this one that we were talking about? Yeah, go ahead.
There was a great question here. With compromised individuals in acute care facilities, what would be the recommendation on when to disinfect? With faster times, are there more complications? With longer times, the dwell time not being reached? Thank you for your guidance. Thank you for that question. So as IPs, that's what we really partner with our EVS people, and we say, hey, what's our goal here? Our goal is to kill our microbes that are on the surface. But he also has the goal of getting this room turned around in 25 minutes. How do we get there? What is the goal between me wanting to make sure the room is disinfected and his turnover time meeting goal, and us keeping the hospital rolling and keeping the healthcare system going? Those are the things that we really, really have to focus on. Remember, if you go with a higher concentration of a disinfectant, you are more likely to create wear down of your equipment quicker. But if you go with a lower concentration, your turnover times are going to be lower. So you have to take all of that into consideration, speak with all the key players, and have a multidisciplinary group and say, how are we going to achieve this within our healthcare facility? I hope that answers your question.
Great. Well, we've had a lot of good discussion, a lot of good demonstration, a lot of good information. We're going to wrap up our webinar now. Just a quick reminder, we will be sending out the information from this webinar via a link that you can watch this on demand. You can also visit our website at professional.contecinc.com to reach out to one of our technical supports people or our sales reps. We'll be happy to help you in any way we can. Thank you so much for joining us, and have a great day.